Hi, I'm Andy Zeitlin from Canopy Crossroad. We are the ultimate in Red Bank cannabis. We run a lecture series on some of the more disciplined areas of cannabis and how we can understand it better. This is being done in conjunction with Red Bank Mayor's wellness campaign. And we're very proud to sponsor tonight's talk by Don Paresi of Bennabis Health. Don is going to talk to us about the use of cannabis and a better understanding of how to use it and how it may actually turn out to be useful in medicine and actually have a benefit where an insurance company could provide that benefit to their employers. So with that, Don, take it over.
Thank you, appreciate it. Thank you guys for coming. So you see up here, the name of the company is Bennabis Health. This presentation is really not about Bennabis Health. This presentation is about cannabis. But a foundation of Bennabis Health, because what we're after is to try to get medical cannabis to be a covered health benefit by employers. The foundation of our approach there is that cannabis is medicine. That's absolutely what we are foundationally believing in. In fact, I was at a conference a couple of years ago down in Miami, and there was a student walking around with a camera, and he was walking up to people. He had a microphone, the cameraman was behind him, and he would say to anybody he walked up to, first word that pops into your head when you think about cannabis. And you know, he's expecting people to say all kinds of crazy things. Well, I said medicine, and he went, what? What did you just say? And that's because that's what we believe in. You know, we believe that cannabis is a medicine. So one of the things we're going to see in the slides is that the human body actually has a cannabinoid system. And it wasn't even discovered until the late 90s that we actually have that kind of a system. It's all about trying to help your body balance itself in all different ways. So this is something that could, you know, potentially help that. That's why we look at this. Cannabis, from our approach, is not curative. We don't believe that that has been proven, so we don't even try to make that claim. We make a claim that cannabis can help symptoms, and it can help symptoms so much that people can be productive when they otherwise wouldn't be able to be. So the cannabis plant is a natural plant. It has what they call phytocannabinoids in it. That word starts with a P, so it basically is associated with plants. That's true for a lot of different plants. There are over 100 cannabinoids in the cannabis plant, and only a few of them have actually been studied enough for us to be able to talk about it. The plant also has other things in them that are in other plants too. Terpenes, that's something that's in the cannabis plant, but that's also in a bunch of other kinds of plants and vegetables. Carrots have a terpene in them that actually makes the carrot orange. But the terpene part of the cannabis plant is an essential part to try to help the medicinal components to work, right? So that's kind of the foundation of what we're going to talk about here. And every time I move over to hit the slides, I'm going to end up right behind.
I know.
Sorry about that. Okay, so one of the things that we want to make sure that everybody's aware of is that we are now starting to see, and have been over the last 5 to 10 years, increasing acceptance of cannabis as a medicine. In fact, when the federal government put out a proposal that cannabis should be changed from Schedule 1 completely illegal to Schedule 3, which is where Tylenol with codeine is, they actually put a whole bunch of data out to try to support that. One of the pieces of data that we found to be really interesting was that the CDC had done a survey in 2022 of millions of people, asking them a whole bunch of questions, one of which was, do any of you use cannabis? 8 million people said, yes, I use cannabis. And then they were further asked, that's clearly a good sample size. And then they asked them further questions like, what do you use it for? 2/3 of them said they use it in whole or in part for medical reasons. 2/3. So that's a powerful comment. That's, you know, most people, by far, who use cannabis are not using it just to get high. They're using it for medical reasons. That's huge. So, you know, as I said before, it's used for lots of treatment of side effects, certain conditions. We're going to get into that later on in the presentation. We need to educate people. That's part of what this is about. I'm going to try to produce a balanced kind of approach here, so that we're not going to be advocating for anything in particular. Like I said before, we will never advocate that this is a curative medicine. So that's kind of what we're going to try to do here. That's an education course. And by the way, for the nurses in the audience, we actually have a partnership right now with a professional nursing organization, nonprofit, that is made up of registered nurses who are experts in cannabis. And the company's called Leaf 411. We actually provide the ability for anybody who's curious about cannabis but just can't seem to get over the hump because they don't know what to ask when they walk into a dispensary. These nurses can help guide them along. Just sort of make them feel comfortable. They could potentially make them feel like, okay, this isn't for me. That's fine. You know, they're not advocates for Bennabis Health. They're just educators. So we provide that service to anybody who wants to go through our website, go to Leaf 411, call them up. It's on us, not on the patient who's calling, right? So that's the education point. And you know, we're out there with the stigma and start talking about it. That's why I was very happy that Andy asked me to come here. So look how many Americans are now ready. There's 88% of Americans support legalized medical cannabis. That's a big number. 40 states, you can see in the next couple slides, now have medical cannabis approved. 40 states. And of the 10 that don't, some of them have CBD, some of them have indigenous nations in their boundaries. The indigenous nations don't have to follow state laws, so they actually have cannabis in those states. Like Nebraska has an indigenous nation that's got cannabis. They're allowed to sell it to not just tribal members, but anybody. But Nebraska doesn't legalize it, but that's what the indigenous nations can do. So we have a lot. I mean, look at the size of that market. The cannabis market is expected to exceed $71 billion by 2030. It's huge, and it's continuing to grow.
You know, the pharma component is that they're very, you know, pharma's very opportunistic for something like cannabis. They'll know the science inside and out, and they'll probably have written some patents already by now. But to actually get a medical review board to support a pharmacy study for cannabis in any capacity, you know, phase 4 or even it's just there's just no appetite, you know. So it's and the one area where there is a use is an appetite stimulant. but that was an opportunistic thing. It was actually for cachexia associated with weight loss and AIDS, so it was a totally opportunistic thing.
And some people on chemo were getting it.
Right, and it's the same mechanism for
but
chemo.
They still haven't taken off Schedule 1, right?
Yeah,
I mean,
no.
how long did we talk about that?
It's just crazy, but I don't believe that pharma's ever gonna go beyond that.
Yeah, you know, one thing the federal government did that was a progressive step in the last couple of years is that until 2 years ago, the only place in this country that could provide cannabis for study was the University of Mississippi.
Yeah,
And the cannabis that they were producing was really
it was
not
garbage.
good. It was not good.
Yeah.
So the DEA a couple of years ago allowed for, I think it's 6 different places around the country that can be cultivators for cannabis, but if you use them, those organizations, those cultivators, and use their product, and it's studied at DEA approved places like Drexel University does it, for example, then you can actually have better studies. But that's only in the last couple of years.
Yeah.
So it's
And I don't really think that improves the quality of the study. You know, because those sites, they're using GMP manufacturing techniques that all of the producers are using now.
Yeah.
So the quality argument is not there anymore.
Yeah.
It's the clinical study. What are we studying it for? You know, and sleep is I think, as we talked about, but whatever.
Correct, yeah, we'll get there. Now, the reason this slide has a plus on it, you kind of look at that and you go, 72 plus, really? What kind of a number is that? Because mine should just put the right number in. But the reason the plus is in there is because it changes so frequently. We didn't want to have to change the slide every time there's a new condition. There's actually so many conditions that are in that 72. There's only, I think, aside from W, X, Y, and Z, there's only 3 letters of the alphabet that don't have the condition associated with them that cannabis can cover. You'd never believe what the 3 letters are. One of them's J, one of them's K, one of them's B. I don't quite get that, but all other letters are covered of things that cannabis can affect. Again, it's conditions. It's conditions means not just diseases. It means It can include nausea. That's not a disease. That's a condition. It can include vomiting. Those are things that cannabis can help, but that's part of this.
A lot of people
this
sleep.
And
Most people
sleep.
I talk to, they say
Yep.
really, they've tried everything, it helps them with sleep, yeah.
All right, so these are only 12 of the qualifying conditions in New Jersey. There are actually 17 of them, but these are the biggest ones. I mean, you'll see the kinds of things we just talked about. Chronic pain is in here, anxiety, opioid use disorder. One of the things that we are, sort of prone to say whenever we have the chance is that whenever I've done these presentations, it's been pretty clear. Now it's getting better, but it's been pretty clear that as I'm speaking, somebody's probably dying from an opioid overdose. That's probably happening. But we also say that we have never heard of one reported instance where there's been a death from an overdose of cannabis. Not one reported instance throughout the country, maybe even throughout the world.
I mean, it's also documented that opiate use has gone down since cannabis has become.
Yes,
Yeah,
right?
So.
So pretty clear.
besides Narcan saving everybody else's
Yeah.
Epilepsy and seizure though, I was a school nurse, and there is medical marijuana used in New Jersey schools also.
That's right, CBD.
And it's accepted, it's written into our guidelines, which I helped write, so I know
Excellent.
what's in there.
Good job.
You're getting somewhere, and you slow but slow.
I have a question
Slowly but
about
surely.
the opioid use going down. Was this study done in New Jersey where they saw the numbers going down, where cannabis is, in the states where cannabis is legal?
I would have to get you that reference, but I'm pretty sure it was a national. It wasn't Jersey, it was a national figure.
International, okay.
But
And-
the good news about the studies like that is that the two groups are so easily identified. They can go to the states that don't have medical cannabis and the states that do.
Right,
And they can
Right.
see what the impact is, and then they're able to make a conclusion as a result.
yeah.
They even did that was one of the oldest studies we've seen.
I'll look through it for the
Back in
reference.
2017 or 18, Temple did a study about people who were making workers' comp claims and how fast they went back to work in states that had medical cannabis versus states that
Oh.
didn't. And people were going
That was
back to work
interesting.
faster in one particular age cohort, 40 to 50, I think it was. Those people were going back to work faster in the
Because
states
the
that had
chronic pain
medical
isn't that
cannabis
there anymore.
because they were able to be more productive by
Right, they're
getting
not gonna fall off a
and
ladder.
that side effect of, I mean, I was on the board of one of the first dispensaries in New Jersey, and when we were seeing patients come in, we were finding that people weren't able to get out of their bed unless they had their cannabis. So, you want people to be productive. So that was a help. Now,
I'd
it's
like
not
to
help,
see that
it doesn't help
study.
everybody. I want to be balanced here. But
Yeah.
those situations we saw.
Yeah,
All right, now there are side effects, so we want to be clear about that. There are some side effects. It can make you dizzy, change your appetite, sometimes change your mood. When we get into the whole discussion of what's in the plant, the CBD component, the THC component, and the terpenes, you probably already know this, but the THC component is the psychoactive one, the one that can actually make you feel high. The CBD component is one of the cannabinoids that helps medically. We've heard, I think this is going to be continued to study, but we've heard that the CBD doesn't really get properly triggered for medicinal purposes unless there's a little bit of THC in it or a little bit of terpenes in it.
Yeah.
On its own, it helps in certain situations. That's why you see CBDs being sold at drugstores, pharmacies, or Quick Check. So it does help. But when we talk about medical cannabis, we're not talking about purely CBD. We're talking about CBD plus THC or terpenes, or more likely than not.
And the science backs that up, that, the mechanism being modulation of CB1 and CB2, there you go.
Look at that. We didn't even practice that. That was really well
I should
done.
tell you that I taught substance use and abuse for 21 years. So the fact that cannabis has stayed on Schedule 1 all these,
Yeah.
is to me just bizarro.
Yeah.
The research, and I haven't taught 3 years, but
Okay, so this
The one
is-
thing I was gonna say before you
Go ahead.
just so I forget my point, the CB1 and CB2 are both exquisitely sensitive allophatic receptors.
Yes.
So what that means is that, terpenes, cannabinoids are all very aliphatic, they're very fatty type substances, and those both receptors are responding to that chemistry, the cannabinoid terpene chemistry.
So when we talk about the human body having its own cannabinoid system, we call it endocannabinoid. That's the E that you see here, ECS, endocannabinoid system, right? If it's not naturally produced in the body, we call it phytocannabinoid. There's also synthetic, but we don't talk about synthetics. We like to stick with the natural parts of the plant.
Delta 8 is synthetic, by the way.
Yes, yeah, and we're not really happy about that. But this slide we're going to spend a little time on because this is important. This is part of what was discovered only in the 90s, that we have sort of this balancing system within our bodies that's called the cannabinoid system, endocannabinoid, because it's natural to the system. It sends signals to the inside of the body. The CB1, CB2, as Andy said, are receptors. And the ultimate goal here is that just like in your body you have natural, say, for example, vitamin D, you don't necessarily produce enough of it. So you go and take some more, you drink some milk, you do, those kind of things can help. This is what the phytocannabinoids can do. They can add to the endocannabinoids, and so help the body deal through brains, lungs, vascular system, muscles, to deal with the kind of conditions we saw before. Like, you can see muscle spasticity, I always say that word, spasticity, chronic pain, those are kind of things that, the receptors would attach to the right parts of the endocannabinoid system and help, right? It doesn't help everybody, and in fact, the cannabinoid system inside every human is probably a little different from one to the next, which is pretty amazing. So that's going to make it a little hard, I think, to do the kind of studies that we all want, that Andy definitely wants, because every subject is probably going to be a little different. So we have to take that into consideration.
So the way that's handled, and because that's not unique to pharmaceutical development, that you basically have a subset of the patient population you're trying to look at that are sensitive, and so that's commonly done.
Yep. So that's the CB1 and CB2 receptors are the most important part of this. But the fact that it's naturally within the human body is not something that people really know. Only those of us who've been in this industry where we treat cannabis as medicine recognize that this system is naturally within the human body. And so we're trying to help buttress that, just so that, like I expressed with that vitamin D example. Okay, so one particular condition, rheumatic condition. It's a game changer for lots of people. Neuropathies, fibromyalgia, osteoarthritis. Look at that number. It's almost 2/3 of the patients have substituted medical cannabis for traditional prescription medications. That's a big number. Non-steroids, anti-inflammatory drugs, 55% opioids, almost half, sleep aids, 30%, muscle relaxant, 25%. And better symptom management. We're going to see later in the slide presentation the kind of survey results that show positive positive patient reactions, like good, great versus or negative. When you see that slide, it's pretty eye-opening. This is how many registered medical cannabis card holders there are in the country. 5 million people. Now, what's a medical card? A medical card is the cannabis version of a prescription. All right? Every state, welcome. Every state that has adopted medical cannabis has substituted a medical card for what is typically done under the Controlled Dangerous Substance Act as a prescription. So what we're doing at Bennabis Health is trying to normalize that whole thing. You compare going to a doctor to get a prescription, getting your prescription, going to a pharmacy, getting it filled, to going to a doctor, getting a certification from the doctor that you have one of the conditions that the state says allows you to get a medical card. You then go get your medical card. Instead of a prescription, you're getting a medical card from the state. That does take a little longer than just walking out of the doctor's office with a prescription, but it's not terrible. And then you go to a dispensary like Canopy Crossroads, and you get your medicine because you have a medical card. Now, in states where it's recreational now, we call it adult use in New Jersey, a lot of people are like, I don't really want to get a medical card. You know, I can just buy it recreationally, so what's the difference? Well, when it comes to getting this covered by health plans and employers, the medical card is going to be key. Coverage does not happen for something that, you know, you don't get non-prescription drugs covered by your. So if we're going to use the card as a substitute for prescription, the card is going to be pivotal to getting the coverage, right? We have to make sure we do that. One of the things that we were really happy about is we actually have 3 groups in New Jersey who have signed up to give their employees access to medical cannabis. We actually made U.S. history, we think. Back in January of 25, we got 3 groups, all public entities in New Jersey, to say to their employees, you have access to medical cannabis through Bennabis Health. You know, it's just a discount card, it's not coverage. It's not the same thing as walking in and paying a copay. You're just gonna get a discount. Unfortunately for Canopy Crossroad, none of those groups are here. They're not in Monmouth County. But there are 3 different places around the state. We actually made the front page of the Star Ledger back when it was still doing print versions. The bottom of the front page saying we think we've made U.S. history. This is the first time we think in the country's history that an employer who's not already in the cannabis industry is allowing their employees to have access to medical cannabis. And so that's only been in place now for the last 7 months. You know, it's pretty new, so you know the uptake's not quite what we want, but you know we continue to work on that. It's not the same as coverage. Once we get the coverage, the patient's approach at the counter is going to be quite different. Right now, the patient's approach to the counter is to present their Bennabis Health card, they get a discount, which is what would happen if they went to Canopy Crossroad. If they get coverage, they would go to the counter and pay their copay, just like they do at a prescription counter. That's a huge difference, right? Instead of a 20% off, they could get 90% off. You know, like that, and that doesn't hurt the dispensary because the dispensary gets the rest from us. You know, so it's not like they're having to fork over the medicine for a 90% discount. So that's where we want to get to. But yeah, we've gotten that far along. And with 5 million registered cardholders around the country, you know, those people can all benefit from this, and then there's a lot more. Look at the baby boomer reaction. Almost 90% believe that cannabis has medical benefits. That's where we are. Over 60% prefer cannabis over a prescription for pain, if given the option. That's the big if. Yeah. And almost 2/3 feel that the medical provider can give accurate information on the benefits of cannabis, which is pretty cool because I would have thought it would be 36%.
Mm-hmm.
Now this is the survey of how well people are reacting. 95% gave either an improved slightly or an improved significantly reaction to how has cannabis affected your life. And only 4% said stay the same, and less than 1% said it worsened. That's a pretty good, you know, if you're going to have a kind of survey that's going to show people's positive reactions, that's a pretty good one. You know, if we all had that kind of customer service reaction to our businesses, we'd be pretty happy about that. Here's a specific patient, all right? Cancer patient from West Deptford Township, pancreatic cancer, OxyContin. He hated it. So he talked to his doctor, and the doctor actually said, try cannabis. Everybody calls it marijuana, we call it cannabis. So he takes his chemo because he has cancer. You know, he's got nausea from the chemo. He has all kinds of the side effects of chemo, which are awful. When the pain starts, he takes the cannabis and it goes away. You know, that's pretty cool. I actually had somebody from the New Jersey State Health Benefits Plan ask me if there was a study out there that showed that taking cannabis actually helps people stay on their chemo. And that study actually exists. That's a National Institute of Health study. So I sent it to her, and she was pretty impressed because, you know, if people aren't going to continue their chemo, you know, what's the point? But if this could help them continue their chemo, then obviously it's better for the patient. And actually, it's better for the state health benefits plan because those people get to be productive again.
Yeah, oncology is a great use, but I just got off of having a herniated disc. And if you look at that previous slide on all the areas where cannabis is useful, a herniated disc is neuropathic pain. It is anti-inflammatory responsive. I think it was the next one. So there's a couple of conditions where the condition itself is a pleiotropic kind of thing going on in your body, that there's multiple things that are out of whack. And in some cases, like in the case of chemotherapy, in the case of neuropathic pain from a herniated disc, cannabis is it's perfect in a lot of ways. You know, in the case of steroid sparing for pain, I experienced that when I was recovering from a discectomy. So it was a significant surgical procedure. So it really is. It's the use as an adjuvant is where cannabis can be added to so many different regimes that make people's lives so much better. And it's that steroid sparing thing or the opiate sparing. It's the effects on wellness. It's just the quality of life measures. So anyway.
And I gotta tell you, I did not expect to hear a word I've never heard before today. What did you say at the beginning there?
Pleiotropic?
Yeah, what is that?
Pleiotropic refers to something that has multiple different mechanisms of action. So something that is pleiotropic, it could be a disease that has many different manifestations, or it could be a drug causes many different side effects, or it could be a drug that has a lot of different activities.
I love
Those
that.
are all pleiotropics.
Thanks. Did you take a picture that you wanted?
Yes. I just made slides, sorry, don't worry.
Well, that's all right.
I'll get it on camera.
She's doing this on YouTube, yeah.
This one's pretty important. You should probably take a picture of this.
Yeah, that's a cool one.
All right, so now we talked about John. Now, this is what we're finding with respect to Medicare recipients. Unfortunately, Medicare covering cannabis is probably going to be the very last thing that happens, because the federal government has to get completely out of the way and say, yes, we agree that this is actually got medicinal value. But regardless of that, Medicare patients are spending out of pocket to use cannabis. The numbers are pretty high. We're talking about almost a third of the people who seniors who suffer anxiety are taking cannabis. Pain, you see the kind of things that we already talked about, anxiety, chronic pain. Glaucoma is an interesting issue. A quarter of the people are finding that cannabis helps their side effects from glaucoma. And that's actually been true for quite a few years. Question?
How are people, say the Medicare recipients, taking their cannabis? Are they smoking it, drinking it?
Yeah, I mean, right now, although it's diminishing, the most popular way of intake is still smoking it.
Smoking?
But
Inhalation?
it is actually, that actually is declining. And that's because the market is starting to respond. And, inhalation, as any medical professional will tell you, is
It's better
not
than
the best
most.
thing. It'd be better to take a gummy or a topical or something like that, and the
Right.
market is starting to respond.
Okay, I was just curious.
And there's our opioid use slide that we talked about earlier.
Yeah.
That's a pretty big number. 79% of participants reporting
It works.
stopping or reducing. That's another thing we want to make sure we're clear on. When we talk about cannabis as a substitute for prescriptions, it's not usually in whole. It's usually in part. It's usually in part. But still, because our perspective, of course, is on the health benefits plan side of the equation, even a partial reduction in pharmacy costs is not going to be overcome by the increased cost of cannabis to be covered. So we think it makes financial sense. This is what we're talking about. The top bar is the sum. The bottom bar, the white one, is all. So, the white bar is obviously a lot shorter than the top bar is. So most people are reducing their prescription coverage in part, right? But look at all those conditions: opioids, muscle relaxers, arthritis, anxiety and antidepressants, sleep medications, anti-migraines, nausea suppression, all those things that we've talked about. This is how much people in Medicare are spending on cannabis. Now this is not covered.
That's a lot of money.
That's a lot of money. You know, so we're trying to get people to the point of at least getting, most dispensaries provide a discount to seniors, you know, a fairly sizable discount, which is great. But it's still, you know, it's a lot of money. And we got, if Medicare would ever say, if the federal government would ever say, this is medicine, and Medicare starts covering it, then more people would have a shot. And that's why we did this. I mean, at one point I'm gonna talk about how Bennabis got started. Here's another example. Nurse practitioner and mother had an epileptic son, 18 seizures a day, right? They heard about cannabis, thought they'd try it. The teacher called and told her that he was now active and doing well in class and he had never been before. Sometimes he even had seizure-free days. So that kind of sounds curative. It's not. It's not curing his seizures. It's not curing his epilepsy or whatever he has that's causing him his seizures. But it's affecting the gravity of his seizures, so that he has fewer of them, or if they have them, they're going to be not as powerful as.
Well, you know, I worked on Focalin, which is the single isomer of Ritalin, which is the main drug for years and years and years. And the biggest issue was compliance and getting kids to take their meds through the course of the day. So what drug companies did is they developed a once-a-day dosing regimen where they take it in the morning and it lasts the whole day. That is just getting compliance changed how people perceive ADD and what you're trying to treat. What you're really trying to treat is kids that are in school. You want to keep them in school, right? So this is a classic example that it's another example of where the drug is providing the kid the ability to stay in school.
That's right.
So you can't underestimate that.
Yeah, we're trying to help people become more productive, whether they're children suffering seizures or people got hurt on the job and they can't go to work because the pain is just overwhelming. All right, so this is us. We tried to build a dispensary network to tell health plans that they can get a break in price if they cover it. Canopy Crossroad is in the network. Let me tell you why Bennabis Health was created. I was on the board of one of the first dispensaries in New Jersey. As I said before, there were so many times where we saw people who could be helped by the drug but couldn't afford it. And so they all turned to me. I used to run a health plan actually that was based in Red Bank in the 1990s. First Option Health Plan. I don't know if you remember that. It's a long time ago. Were you a shareholder?
No, I heard it.
You've heard of it.
Because it was owned by doctors and hospitals.
We're your provider, you're.
Yeah, right. So that was in the Galleria. So the guys all turned to me and said, you ran a health plan. What do you think we should do? And I said, well, let's try to get it covered. And the way to get it covered is to create a network and market it. So that's what we're doing. One of the other sort of real pressure points that made us want to do this is one of my co-founders has MS. And she was diagnosed in 2012. Her doctor wanted to put her on the traditional MS drug regimen, but she had to go through all the side effect testing and stuff, and she just said, yeah, I don't want to do that. She already was sort of a proponent for cannabis. She said, I'm going to try that. And the doctor said, boy, that's really risky, but you can make that choice, so go ahead and make it. So she's now 13 years, and it works. She's been able to handle the side effects of her MS. But she also recognized that she, unlike so many other people, was financially capable of purchasing her cannabis. The MS drug regimen cost $9,000 a month just for the drug. $9,000 a month. She spent $1,000 a month on cannabis. So her health plan was saving $9,000 a month. But they also would have saved $8,000 a month if they just covered the cannabis. But she was like, there were so many people who should be able to make that decision and they can't. And so we just said, we need to help people try to get to the point where they can make that decision. So we want people to have that opportunity by getting it covered. And if we can get it covered, they have the same choice that she had. But she only had the choice because she was wealthy enough to do it.
So on page 103 of the school nurse guidelines, it goes over meeting the needs of students with chronic health conditions, medical marijuana.
Good.
And the school health guidelines are published by New Jersey State School Nurses in conjunction with the Department of Ed. So the school nurses are kind of been ahead of this on the
Right.
curve. I
That's
mean, whether it's covered or not is really sad, because then you're gonna see who can get it, right?
Right. Yes. The
And
poor.
you're missing out with the big
Yeah,
population.
poorer families are not going to be able to do it.
Yeah.
The wealthier families are going to.
But there's stuff in here from the DEA, the National Association of School Nurses, which I'm a fellow of, IDEA. So there's a lot of support and a lot of multiple sclerosis is in here.
Yep.
Lateral sclerosis, terminal cancer, muscular dystrophy,
All the things
inflammatory
we
bowel
said.
disease, including Crohn's disease, and terminal illness. If the physician has determined the patient has terminal illness, then it goes on to say seizure disorders, including epilepsy, intractable skeletal muscle spasticity, glaucoma, which we talked about, post-traumatic stress syndrome.
You can tell she's a nurse because she said spasticity without a problem.
No specificity problem.
I also don't write these guidelines, so it's just when I
I was
have
gonna
to
say,
pull
that's,
out
you
just.
did write that, right?
Yeah, really, we
Good for you.
did. It's, I'm on the board of New Jersey State School Nurses Association, and I'm the Standards and Practice Chair. So we update these continuous, it's a live document, actually has to be redone again. But this is NJDOH from 2017, so it's going by the New Jersey Department of Health in
One of the things that you
2017.
might be interested in is that of the 3 groups I mentioned earlier that have decided to give their employees access to
Mhm.
medical cannabis through us, 2 of them are school districts.
Or who?
School districts.
School districts, yeah.
For the employees of the school district.
Yeah,
Yeah,
well, that's great to hear,
yeah, it's pretty cool.
yeah.
But that's the last slide. So
I guess they're not drug testing now there in these districts,
actually, that's an interesting question.
because everybody's gonna ask that.
Yeah, I mean, thankfully, in New Jersey and in many, many states now, the courts are making a distinction between what is present versus what is impairing. You know, like, people, just use this as an example. You go to work, you know people who at lunch go out and have a drink because they're having a business lunch.
Mhm.
They come back. Okay, they have alcohol in their system. Are they impaired? No. But they have alcohol in their system. So, medical cannabis, okay, it's going to be in their system. If they're impaired, yeah, they deserve to get called on the carpet for that.
Mhm.
If they're not, it's just because it's in their system. And they need it for something like a replacement for opioids or something else like that. So, we're starting to get there. You know, there's still, we know as a company that we're never going to be approaching an insurance broker to say, bring this to your trucking company client. We're not going to do
Right.
that, because they're never going to do it, and nor should they, right? So, but an accounting firm, a law firm, any place that could be, doesn't have to worry about commercial driver's license, is a good candidate for it.
Yeah.
But we're trying to be balanced.
So I have a really good key point, 'cause I have to tell you, these guidelines are really nice, you should look them up.
I will.
Not just because I wrote one out, right? But anyhow, the key point here, Governor Murphy issued Executive Order number 6 on 2018, directing the New Jersey Department of Health to undertake a review of all aspects of New Jersey's medical marijuana program with a focus on it to expand access to marijuana for medical purposes. Recommendations and changes can be found in the medical marijuana report, March 2018, issued by the DOH. Information on changes are accessed here, and we have a click that you can go to. So nurses,
Great.
obviously,
That's great.
you mentioned a group of nurses, so nurses
That's
know
great.
that it works.
Yep.
We really don't like people overdosing in front of us,
No.
And physicians know it works, but it's just like, we had this fifth vital sign for the longest time that they kept shoving down everybody's throat. They had to medicate your patient if they were in pain and pushing opiates at it. It was another whole aspect to
Very
the
glad that
opioid
that's the
crisis.
direction. Very glad.
Yeah.
Yeah, I mean, there's still a lot of work to do. There are, even in states like New Jersey that have approved medical cannabis, there's still some reluctance to do things like, for example, the New Jersey State Health Benefits Plan doesn't cover it.
Mhm.
Why not?
Yeah.
The New Jersey State Workers' Comp System for state employees, not doesn't cover it.
Mhm.
So, you know, and yet the state recognizes that there's a medical benefit here.
Mhm.
So, you know, there are still some things
This is
to overcome.
gray, yeah.
So,
Well,
you know, we can enlist a bunch of nurses to try to help lobby
Yeah.
parts of the
There's
state.
the whole
that need
state
to-
This,
School nurses
this
program.
leaf 411, yeah, there's, I mean, we've had it in our guidelines for a while now. I'm trying to think, it was like 3 years ago when I updated these. I don't know, he sees me on the computer all the time. I'm always like walking
It's
around
more
the computer.
recent, because I remember you talking about
Yeah, right,
it.
takes up a lot of my time, but,
Mhm.
yeah, we, you know, school nurses, like, really, you know,
Well, excellent. Thank you very much for your support, and all the patients are really appreciative that you're supporting this, because we're all about trying to get this to help patients. That's the whole.
Thank you.
But that's the presentation. So if you guys have any
Alright.
questions.